So I am delighted to be chairing a panel today. You guys are probably sick of hearing me and seeing me up here, so I'm going to try to not talk so much but have my panel talk. So today we're going to talk about the complexity of long-term evaluation in pediatric neurodevelopmental and neurodegenerative diseases. So I have a couple of slides, or just one slide per investigator to just show, to have them introduce themselves, and then it's a list of the patients that they treat. So I can't remember who's first. Jen.
Okay.
So I'll leave it up to you. Introduce yourself and the patients that you're treating, the n-Lorem patients that you're treating, because I know you're treating a lot more than that.
Hi again. I am Jennifer Bain. Again, I'm a child neurologist at Columbia, New York City. I started my n-Lorem journey with Susanna and Sloan, who I spoke about earlier this morning. I had the pleasure to have 2 additional patients added, one patient with DRPLA, don't ask me to say it, which is caused by an ATN1 genetic mutation, and another younger one with MAPK1P3. And then more recently, I treat 3 girls who you'll hear about tomorrow with HNR and PH2, which is a neurodevelopmental disorder as well.
Yeah. And then I'll move on to Dr. Berry-Kravis, Liz.
Okay. Hi, I'm Elizabeth Berry-Kravis. I work at Rush in Chicago, and I'm a child neurologist that's been doing a lot of work in translation for disease-targeted treatments for neurodevelopmental disorders. And we have on the slide here, we started working with n-Lorem and took over a couple of patients that some of which still don't have their ASO developed for them, but the SCN2A one was the one that had been followed at Boston, but at the time they weren't able to treat the patient, and so we've been treating him for over 2 years now, and then we have more recently added an H3F3A patient. We have also dosed 2 PAX1 patients in the last few months with a selective ASO for their condition, but not allele selective. And we have multiple other diseases in the pathway right now, including TUB4A and several other things. I won't go through the whole list, but that hopefully in the future we'll be treating.
Yeah, and I'm just listing the patients here that each of these physicians are actually actively treating, but they have a lot more than they have submitted. So it was just the slide was going to become too busy. Olivia.
Hi, I'm Olivia Kim-McManus. I'm at UCSC Rady Children's Hospital. I'm an associate clinical professor in neurosciences, and I'm a pediatric epileptologist. And I've been treating SCN2A, which I discussed this morning, as well as a TUB4A leukodystrophy and multiple channelopathies and other developmental disorders coming down the pipeline.
And then Mandy.
And hi, I'm Mandy Nagy. I'm a child neurologist at Mass General here in Boston. Our first patient that we began treating had a TUB4A leukodystrophy and has been treated now for just over a year. Our second patient that made it to the clinic is UBTF that we've been now treating for just over 6 months. And I should add on this slide, it's not just me. I have a colleague and research mentor, Florian Eichler, as well.
Right, you're talking on behalf of your entire team today. So I'll go back to the first slide just because, whoopsies, this is really us now, no more slides. So again, you've all been treating patients now. I think you all have one patient at least that has been treated for more than 1 year, if not close to 2 years or 3 years. And I guess the first question is really kind of open-ended and everybody can answer, but like, what was something that you did not necessarily expect at study start with that a specific patient you've had? So anybody can start.
I mean, I think for me, my first patient starting was 14 years old, and so there's some things that were presumed beyond developmental window, and so I think that this was something that we argued also with California Institute of Regenerative Medicine, who supports us, that we don't necessarily know where those limits potentially could be, and so we did see, new onset gait, independent gait at that after ASO dosing, which we submitted additional scales to follow that as part of our clinical protocol after study initiation.
Well, I think so. What we discovered with our first patient was positive in that the seizure frequency got better, and we were able to take him off of Dilantin over time. But I think what happened during this, I kind of thought we would start this ASO and it would get rid of the bad overexcitable channels, and that would be it. But we discovered that in balancing multiple medicines that work on sodium channels along with the ASO, you walk kind of a fine line, and it may not be as simple as just getting rid of the overexcitable channels, because everything works in circuits in the brain. And so we've had to do a lot of attempts to dose adjust and adjust the timing of the medication to try to be in the right place where we get those massive improvements in seizures and not kind of go over the top and have too much drug or too much sodium channel blocking activity. So this has really been kind of a tightrope walking experience, and I think we've learned and we're doing better now, but that was something I didn't really expect. Mm-hmm. Although maybe should have.
Oh, yeah, we learn.
So I'll say, you know, with regards to Olivia's comment, for Susanna, we did not expect the tremor to get much better. Like, that wasn't even something we were thinking about. And because we noticed that clinically on our exam, which didn't necessarily come up on like the case report form, it was just something we noticed, as well as kind of the cadence of her speech and the quality of her communication. That's when we kind of shifted, so for patient 2, to saying, okay, how can we modify that outcome measure? I think for me, as a, I guess, junior mid investigator, scientifically speaking, everything should stay the same as best as you can, and I try to do this in clinical practice. And so theoretically, for the trial period, we're not supposed to change anything else. And we really want to do that, but we also have to balance being the clinician and saying, like, no, you're having spasticity, we have to treat this with some Botox or something. And so really just continually refining with the family what matters now, and how can we make your life worthwhile now, in addition to trying to be as standardized as you can for the trial.
Right, yeah.
Yeah. And I would say along the lines of things changing in life, one of the things that I didn't expect how complicated it would be is having a patient who has setbacks in the setting of things completely unrelated to the trial. So, for example, one of our patients went to camp, which is a great experience, and lots of kids do it every year. But as you know, many of you families may know, when you're at camp, you're not getting all the therapies and all the activities and all the things that your children might be used to getting in normal life. And so, you know, he came back from camp happier but stiffer and less mobile, in a way that we think is not at all related to the study drug. And thinking about how to capture that and how to incorporate it into our assessments was a little bit tricky when you're dealing with one patient.
Right, yeah, that actually brings a good point. We never know how something is going to impact someone. And I remember when I was working on the myotonic dystrophy trials for Ionis, we didn't realize these people had a lot of GI issues, and I didn't realize that they would starve themselves when they were traveling to the site because they didn't want to have accidents on the plane or whatever. And so then assessing what you were assessing, especially when it was motor function and muscle testing, you're like, well, obviously they're not going to be at their full potential because they're not really hungry. So that's actually...
Like as researchers all on the stage, you know, we like to come up with a good publication, and I appreciate that Stan said, like, we have to publish this, and it needs to be shared with the community for a variety of reasons. If it's not written and published, it didn't exist, right? We know this in the scientific world. I'm sure many of you know there's many more people out there with the genetic disorder that you have than is actually written on paper. But it's hard to say at what point do you get to a point where you're like, all right, this is the story I'm going to tell, because it's an ongoing story and journey. And so the story with Susanna and Sloan, you know, at what point do we say, like, all right, we're going to stop, we have enough information to give this chapter, and now we're going to present that forward. And I think, you know, we're all kind of thinking about how do we balance that sharing of the story and thinking about the next question of the story.
Right, and I think it's, because normally in clinical trial you would say, well, I can't publish until the end of the clinical trial, but is that really sometimes necessary? Maybe the first year story is important to tell, and then we'll tell the second year story later, so I agree with that. Again, you've all have.
I was just going to add one more thing that, you know, it is complex with following development and, you know, neurodegeneration over time, but we can include structure and rigor into these N-of-1 trials too, as much as we can, despite the day-to-day changes. And so I think in trying to employ that, you know, when we can, minimizing change outside of the trial, we were doing that, and even like the same dose, we would repeat the same dose again without any other variables, just to see if there was the same thing over the next 3-month period, because these are things that help keep it a little bit more rigorous when we're able to. Of course, it's, you know, clinical care, if there's status or something like that you need to change and bring to action, but these are ways that we did include that into our design for dosing.
Yeah. And I mean, I think it's also very remarkable to consider, I mean, for some of your patients, you might be the treating physician anyways, but for some of your patients, you might not. And so I think it's been remarkable how you all have been able to treat, you know, patients you may not have known before with all of what you're saying, right? The clinical care is really the important one. You all have more than one patient on treatment, and so, and it, you know, took some time. We started first patient before we started the second patient, and so you all worked with me and my team on protocol development. Was there anything that you learned from the first patient, even if the second patient was a different disease, that you kind of made you think like, okay, this time we're going to do this differently? I don't know if anyone can go first.
I can go. So I would say our first experience really taught me the importance of that individualized natural history that they were talking about a minute ago. So I think when we were deciding on the trial endpoints and you know, which assessments we wanted to do, we had great input from the family, we had great observations of our own. But the first time around, we didn't have as much longitudinal data as I would have liked. And so with that in mind, the second time around, the very first time we had the thought of, you know, maybe this patient would be appropriate for n-Lorem, for an ASO, we started collecting that data so that we had it longitudinally, and by the time we actually started dosing, we had a couple of years of data that we were able to go back and use.
Yeah, I want to emphasize that point. We got some of our patients kind of from another institution, and so we didn't have as much pre-treatment data as we would like. We had a little bit, because as soon as we knew we were going to have the patient, we immediately brought them up and did assessments so that we could have some pre-treatment trajectory. But that pre-treatment trajectory is really important, and the more you can have, the better. I mean, now for our third and fourth patient, we have several years of pre-treatment data, which is really great. So I think we need to strive to have that. And you know, most of the time there won't just be an ASO ready, but with some of the ASOs that now target multiple patients, people are very anxious to get treated, but we don't really have the pre-treatment background, and we have to figure out how to balance that, the need for treatment soon versus the need to understand what the pre-treatment trajectory was.
Mm-hmm. Anything else?
We definitely changed pieces of our protocol. So initially we were gathering some outcomes at every dose, and I realized we don't need that at every dose. That's not going to change in 4 weeks or 8 weeks or 12 weeks. And then I went too far. I said, all right, we'll wait till a year. And then 6 months down the line, I'm like, oh no, we have nothing at 6 months. We really should have had something at 6 months. So now, you know, really just identifying, and this is me learning as a trialist, learning what are the outcome measures, how long are they going to take to move. A lot of the cognitive things that you're looking at do take time. And I think we're starting to learn about, you know, clinician bias and as objective and subjective data that we have versus other technology, right? Having the wearables, having computer generated, something else that we can use on top of our clinical exam. We're neurologists, so we really like geek out, or at least I do on my physical exam. But really having other ways to measure change and change over time.
Yeah.
Yeah, and I agree, and I think, you know, natural history, we talked about it in the context of gene families or genes themselves, and then also within the individual, and whether or not you're talking about a clinical trial for genetic therapy, I think it's important that you're just following that anyway for somebody over time and having real good natural history collection to tailor your treatment as it exists already. and then as a pathway potentially for novel therapeutics as well. Some of the measures we're following are clinical measures like seizure counts, things like that you can follow. Some of the developmental measures that we employ in clinical trials are not, and they're research measures, and so they may or may not be something that you can incorporate on a regular basis, but there are certainly things that you can follow in terms of development over time too, including your measurements with your therapists and physical and occupational therapists and things like that too.
Yeah, and actually just to build on that, so we haven't officially looked at everything yet, but because a lot of the patients that you're treating are followed by physical therapists, occupational therapists, they normally give yearly updates to the parents, or I don't know, maybe 6 monthly updates, and it's a very standardized report that they give, and it's been really actually fascinating to be able to look at those, and so it's trying to also bring those into and maybe find a way to analyze those, and obviously, it's a different assessment than the assessment you do, because it's really in terms of this patient, what can they do at school, so it's not comparing to, neurotypical patients, but it can really be something that we can use and kind of pull from. Another thing, just to let everybody know, normally as soon as we have a patient who has seizures and I talk to the physician, I'm like, can you tell the family to use seizuretracker.com? So please, seizuretracker.com. Because we use that in our clinical trials to track seizures, and it's a very easy app. You can put multiple caregivers on the same app, and so that's why it really is helpful. However, with that said, even though we like it, we understand how to analyze the data from it, if you've been tracking your seizures on another app and you have that wealth of data, please just continue on that app, okay? So we are trying to really customize it, but in case.
I think about the OT and PT particularly. The OTs and PTs of working with young children often use some of the same measures that we use, and so we've been able to dig back. In terms of natural history, we've been able to go get natural history from a little bit longer ago because we've been able to pull up the OT or the PT doing the standardized test. I will say there's a fair amount of variability between OT and PT and what you get as a report, so sometimes you can use it and sometimes you can't, but it's definitely a source worth looking at.
Right, and especially if we get patients who can use an ASO we already have. Again, like Liz was saying before, we have reduced amount of time to gather all that information, so that's when we can maybe pull on some of those, standardized reports to at least get a lot more pre-treatment data than we can. So some of you are approaching, well, Jen, you already have approached the end of the typical protocol, and you kind of touched upon, what to do in the future, because you're moving from, like a research protocol really to kind of clinical care. I know it's semantics maybe for some people, but I think, how are you all approaching this? And especially because n-Lorem still asks for the data all the time. So we don't actually care whether the protocol ended, because we still want to collect both efficacy data, definitely have to collect safety data. But just from your perspective, what are you thinking, and how do you think we all should think about this moving forward?
So I think talking with the family, and I don't think we and n-Lorem didn't know what that was going to look like in terms of that clear transition point. It wasn't like a aha, we're out of the trial. It just continued, right? And then we said, okay, the data's here, and even on the next publication, it's not going to say end of clinical trial, right? But we did make a clear decision with the family, and there was a shared decision-making process of saying okay, we are going to stop taking the 6-minute walk test, and we are going to stop the false diary because we have to shift our trajectory. And I think we had a really nice, discussion with the family and your team to say this is what the next phase looks like for Susanna. And so that was more of on the logistical end, because from my perspective, I am also a rule follower, and so if the FDA says that we have to follow this protocol, even though she might be very sick in my office at 4 hours, I'm like, no, you have to stay till 6, because that's what the FDA wants us to do.
We like that. We like that.
Yeah, but we I don't. It's not a matter of getting in trouble. I want to make sure that we're doing it in her best interest and we're doing it safely. So getting the data that we think would be helpful and meaningful to the big picture, for her, for other patients in the cohort. And then there's just the logistical aspect of like the funding, which I know, you know, we all have had different roles in terms of like how do you fund the clinical trial portion versus the clinical portion, and that's like a different discussion point. But for me, I think it was more a matter of let's decide, do we think these primary and secondary and exploratory goals are the right ones to continue with for this phase, this chapter? And if not, what do we need to do about that?
Yeah, we had a patient reach 2 years also, and I think one of our concerns was that it would be the end of 2 years and the FDA would tell us that we needed to do something. We weren't sure what, but we just submitted our annual report and we didn't hear back. So I think the way I look at this is these diseases are lifelong diseases. The effects of the ASO could evolve over a very long time. We picked out 2 years. In fact, we lengthened the original 1-year trials to 2 years because developmental disorders, we think, take so long to see change. But really, you know, in gene therapy, we're looking at 5 years, right. And we expect that we're really looking at the lifetime. So the question to me is, do we think the patient benefited from the ASO? If we think the answer is yes, and the family agrees, then we're going to continue treatment, and we're really going to treat it. Yes, we could decrease our outcome measures over time, but I think in some ways, we still haven't quite figured out which ones are the best. So we're just continuing the same protocol, although maybe introducing some other kinds of flexibility into it, like the dosing intervals and stuff like that. Mm-hmm.
Yeah, I mean, I think as it stands right now, we're in the research IND space, so we're implementing our trials in that structure, and so, you know, everything is still, you know, requires a research pharmacy and things like that, and there's just logistical things that are just don't fall into treatment per se in the standard way that we think, but as we're dosing longer and longer and seeing what we're seeing, that just forces us to think about shifting the paradigm. What does that mean, and how does the institutional or broader regulatory levels have to accommodate what we're seeing or help navigate this forward with us? Because at some point it's not going to be research protocols for life, and you know, if somebody's living on this and changing the trajectory of disease, then that has to inform further conversation beyond individuals.
Yeah. Anything you wanted to add?
We're still pretty far out from that transition, so I'll update you next year.
All right, I'll take that. So now I just want to really, again, focus on like the neurodevelopmental and degenerative aspects of things. So we all know, right, in neurodegenerative diseases, patients can like kind of crash and then plateau and crash, or it can be steady decline, right? In neurodevelopmental one, they could be stable and then maybe reach a milestone or not, but you know. So how do you think of those things, and then, you know, we're adding the ASO on top of it when we don't know where the patient necessarily was at? Especially for some diseases we may know because, you know, they all crash around this age, but sometimes we don't. So, I mean, we all struggle with this, and I just kind of wanted to see what you guys think about it. How do we look at that and try to make sense of it? So, I don't know, anyone?
So neurodevelopmental disorders, yes, they are, things go in fits and starts. You get kind of a time when the patient just seems to do a little more, and then you get these stagnant periods for long times. Sometimes you just get gradual development. The trajectory can be anything, but and this is the part about time and why you kind of have to look over a long time, because any short-term kind of decision making really just won't work, because those disorders are, the progress it varies between different domains of development. It can be different, say, for motor skills than for cognitive skills, and the timing of it is really unpredictable, even within the same condition. So basically, I think the only way we can really come to grips with that is to look at things over a very long time and ask, you know, what is this doing over 2 years, over 5 years? But if we really have the sense it's doing nothing, and especially if it's making the patient worse, we wouldn't go on with it. But I think for answers about whether the neurodevelopmental trajectory has improved, we're going to need those answers to roll out over years.
Okay, I'll have a follow-up question.
And they are very complex diseases, so there's going to be ups and downs. When the patient gets sick, then they don't perform as well. And we have to work around all those developmental complexities that happen and try to figure out how to know what we're doing in addition to all the other things that are going on. So it's not easy. And really, in my mind, time is the great equalizer. If you have those things happen, eventually it all kind of rolls out into one time course, which takes years to evolve.
So I would say that, the difference here as opposed to other diagnoses and other disorders is, they're still growing. I have 40, so under the catchment of neurodevelopmental disorder would be intellectual disability. And I have a 43-year-old one with H&R and Ph.D. who's continuing to learn new skills now at 43 years old. That's great. I mean, that's a great thing to hear. However, how is that slope? Like, what are we making that slope for each one of the domains? Motor, communication, social, behavioral, emotional, and then are we normally at this slope, and then the medicine will go to this? It's really hard to say what are we measuring, and I think this is one of the challenges in the field. So are you making a change to the typical trajectory of that person, which as a neurologist, we all know every patient's on their own curve. So we always do that anyway, and we always compare themselves to each other anyway. And then, in a way, I think neurodevelopmental it's different. It might be even more difficult than neurodegenerative. With spinal muscular atrophy, you could clearly say, this is the natural history. We know this will happen. And therefore, I guess Angelman's done a great job of being able to really say, this is what happens when you don't intervene. And then if we give the ASO or if we give this therapy, this is how we can shift it. The challenges that we're all dealing with, one person, two people, five people. But I think one of the comments earlier about how you said we could do better than one N of ones is really working together, not only just like the four of us on the stage, which we do talk pretty regularly about our protocols, but also just knowing that there's a network out there. And realistically, I pretty much know, I don't know a single pediatric neurologist out there who doesn't want to work and try to figure out how to get this to their patients. But how can we do it, and how can we get facilitated from our institutions, from the greater good, to say, like, yes, we all need to do TUB4A at our institution the same way, so we can all get the same outcome measure and do it in the right way.
Yeah, I totally agree. I think the original question about how to think about this longitudinally in disorders that are changing, a lot of it goes back to that pre-treatment data that we were talking about before. I think so far we've mostly treated neurodegenerative disorders where we're thinking about it a little bit differently. Instead of looking for gains, we're hoping that patients stay stable. And in our case, it's been really helpful to have that pre-treatment data of a year or more showing some level of decline. It doesn't guarantee that that's the trajectory they would have continued on, but I think the longer then we were able to get data on stability or improvement, the more promising it is.
Do you have anything to add?
I echo everything that everybody said, and also agree that time does help, in terms of we can try to control variables in trial as much as we can for consistency and, reproducibility, but also life happens and it's an individual, and so we have to kind of work around those things as much as we can while keeping those variables as controlled as we can. And we started off with a coronavirus infection, and seizures come and go, and so we want to see the change over time and a persistent, sustained change.
I think the hardest part is, as clinicians, we're often like, let's just give it a month and we'll see what happens. But as parents, we know that it's the day-to-days are long, and we understand that. But I think the history of each child is so unique, and it's so telling to us that we try to provide you support and solace, that we are with you for that ride. We are, but it does take time, and we can't expect something overnight. We do need weeks, months, years.
I think one other comment about neurodegenerative diseases is that, well, first of all, some of them have various different presentations where they start in at different times of life, and so you're actually going to need like different protocols for those different categories of patients, but if we work together with different groups of patients, we may be able to map that on to specific protocols where we can kind of combine data for a disease like, for instance, Hub4A. But I think another piece of neurodegenerative disorders is that the expected outcome varies based on when you get the patient. So if you get the patient very early in their degenerative course, you have a much better chance of either stabilizing them or actually seeing a little bit of improvement, because there's some neurons that aren't functioning well, but they're still there, they're not dead yet. And if you get the patient with moderate disease, maybe you stabilize them. If you get them with more progressed disease, maybe all you can do is slow the disease down a little bit. So we have to really think about the expectation in terms of the disease progression as well, which just adds another variable to the N of one or N of a few situations where we're looking at a few patients, but we also have a lot of variables.
Yeah, and so interestingly, 2 of you are currently treating patients with Hub4A. 2 of you will soon be treating patients with Hub4A. And so what we have done, as I mentioned and a lot of people mentioned, we have the STAR committee who reviews all the protocols. And we've started now kind of like a variation on the STAR committee, because the STAR committee members are great and Liz is a member of them. But now we have physicians who have treated patients with a specific disease. So now we have committees. We're going to bring people together who have already treated a patient, maybe with a specific disease, to also look at the treatment goals and to help the new investigators or investigators who are treating a new patient. And so I think everything is evolving, but like we're learning a lot more, and now it's becoming, for me, more complicated to get all these meetings on the books, and you guys are just gonna have more meetings. But then I also have a question. You mentioned something before in terms of, obviously looking at motor function versus communication versus, for neurodevelopmental disorders, do you think that there is one domain that would always change before another domain across diseases? Or, I mean, I think I know the answer, but I just have to ask.
If we have learned anything, you can't say a blanket statement like that, because there isn't. I don't think so. No. Yeah.
I would say
or one domain that is more responsive, maybe, to a treatment?
Sensitive.
Well, I think things like sleep and seizures and behavior, which are more fluctuant symptoms anyway, you can sometimes see responses more rapidly. But if you're talking about development, and having a great deal of experience with the Angelman trials, because now we've treated over 60 patients at our site, I can tell you that even in one disease, that actually within the spectrum of diseases is a relatively consistent disease in how it presents. We have patients who have had a better motor response, and patients who've had a better cognitive response, and patients who've had a better language response. And so it's all over the place, and it's really hard to predict who's going to do what. And we've tried to look at, does it depend on how they come in, like whether they're more severe in one domain or another. But it doesn't even seem to map very well to that. So we thought maybe the milder, if a patient was milder, they'd have a better neural network and they would respond better. Or maybe if a patient's more severe, there's more room to move, so we'd see it. We haven't seen those kinds of relationships yet either, and maybe that's just that we haven't treated enough total patients. We might need like thousands of patients to be able to understand these relationships. But I think we have to just, know that we can't really expect to make predictions like that yet. And there may be disease specificity for that, but we have to discover that.
Well, and I think that's also what's very important then, actually. I mean, that's the point, right? Yeah. For families to understand. So if you know somebody that has the same mutation than your child, and they responded, let's say, to the ASO, and they saw this and that and the other symptom, improve first, that won't necessarily repeat itself in the next patient. And so I think that is important to tell, like, every patient will have a different trajectory.
Yeah, and I think that's not a bad problem to have, that there's multiple potential modalities that could change, and so, a selection of the right endpoints to follow that, and having the individual run-in, again, to know what is more affected in your child versus not, and can help inform that. But again, I think that kind of speaks to plasticity on many levels, and that's not a bad issue.
And I would add on that, as a clinician, I can say the same diagnosis spiel to 10 different families, and it's received differently, the interaction is different. And so, quality life is something that we measure, but it is very different to different people, that individual person as well as the family unit. And so holistically speaking, on like a psychological level, like what is meaningful to each family is going to be very different. And so, and what changes are meaningful clinically, it might be very different for a number of patients. And importantly, we can't let that confuse us so that we all use the same protocol, but yet, you know, I might see a little bit better domain and communication, you might see seizures, you might see motor, so that we are able to put all the protocols together and make some meaningful outcomes, conclusions based on that, even though clinically things might be different and different meanings to different families.
Yeah, and we always ask the family what's most meaningful to them in the design, but we also understand that we need to have multimodality outcomes, or we're never going to be able to compare across protocols, you know, what happened to who. And this actually has been one of the problems, not for N of 1, but at the FDA for diseases like Angelman syndrome, where we don't know what's going to get better, but the guidance is to pick the one outcome that's going to improve, and that's really hard to do when you're treating a genetic disease with multiple types of symptoms that may improve at different rates in different patients, and you don't want to miss a treatment effect by picking the outcome that this or that patient didn't have improvement in when they had improvement in other things.
Yeah, for sure. As we're nearing to the end, I did want to, you know, ask something. So you all are treating obviously pretty young children. Those children will become teenagers, the teenagers will become adults. And so, you know, just kind of how do we see that? You know, obviously you're still treating patients that are 43 years old, but how do the patients really go through that trajectory? And I know we've heard that a lot from families also who are saying, well, you know, we don't have a pediatric neurologist anymore, or, you know, my child is 26 and can't go there, or anything, but also even in changes of, you know, the treatment. So just kind of getting your opinion, and maybe we can start with with Olivia on that end and come this way.
Okay. I mean, I'm happy to start on that. Yeah, I think this is going to be a growing, and it already is an existing issue with transitions into adult care and the complexities of that and all the need that comes along with it, therapies, beyond even talking about a clinical trial, but just you know, existing transitions. And so I think that the more we have genetic therapies that change trajectory of disease and people are living longer, that there's going to be more need for infrastructure level support on the adult side as well, and informing what is happening. I think we're seeing this across conferences too, in terms of, you know, Academy of Neurology, Child Neurology Society. These are things that are coming up that are in frequent discussions. We were all in Child Neurology Society last week, and so I think it's going to be a growing need and become more and more complex, but does need to be addressed at the forefront. There's no simple answer except to continue to, I think, also increase awareness that this is going to be a growing need, so that there is more engagement on the adult level.
Yeah, I think a lot of outreach and education and discussions with colleagues, especially, you know, as pediatric neurologists, thinking of discussions with our adult neurology colleagues about, you know, the advances that are being made in pediatric neurology and the changes that may be coming down the pipeline. I think we're in a fairly, not unique, but a different situation where our leukodystrophy clinic kind of spans pediatric to adult, and we just keep the patients, and that makes it simpler. But there are lots of subspecialty care that needs to be transitioned. There are, you know, new issues that come up in adulthood, and I think when we're thinking about what we know about these diseases and how they develop over time, you know, even something that fundamental is likely to be changed as we're treating them, because we know, you know, what does this child or what does someone with this disease look like when they're 10 years old, but they've never lived to be 30 years old, so we don't actually know what issues will come up at that point. And I think that's only time will answer some of those questions.
So I think it depends on a lot of factors. Obviously, institutions may be very specific. At our institution, if you're in the hospital, you have to go to the children's hospital, which is much more expensive than the clinical research overnight, because the code cart is weight-based, and so therefore I can't have pediatric patients in that place. It's also smellier and uglier, so most patients prefer to go to the children's hospital. And now that I'm going to be treating older people, they're probably not going to be allowed. Like I highly doubt they're going to let 43-year-old patient there. Though the other specialties are doing the same thing, and we have a very big cardiac program, and their cardiac patients are now in their 20s, and like they hold on to them. Like we hold on to our patients as long as we can. You know, for neurologists, we're boarded in neurology with special certification in child neurology. So theoretically, I can care for somebody across the lifespan. I think the reality is we have to keep working with organizations. I'm on a work group called the American Academy of Neurology section on adults with intellectual disabilities, and I'm on it not because I'm an adult provider per se, but I need to know where my patients are going to go. But frankly speaking, I do take care of patients in their 30s and 40s because I do know the disorders really well. I think as a field, we're continuing to find more providers who are able to care for patients as they're getting older. Even our SMA patients who, they don't want to go to the adult side, but they'd rather stay with us because we've been with them for so long. And you know, I think it's a hard transition that the whole field is trying to grapple with.
Yeah, that's definitely a huge issue. I mean, I have Fragile X patients who are in their 60s now, and I've been following them since the 90s. So I follow all of my patients into adulthood for the very same reason that I'm a neurologist, and we're kind of certified in both areas. I have privileges in adult neurology, but not all hospitals can do that, and we can't keep seeing all of the new patients as well as seeing everybody through the lifespan, because it becomes very, very difficult to get an appointment in clinic when you're doing that for 30 years. So we do need solutions, and we actually did a session at the ANA, the American Neurological Association, on transition of care this year, where we talked about Down syndrome and Fragile X and general issues with transition of care. And I thought we would have like no one at the symposium in the room because it's mostly adult neurologists, and the room was packed. So even they have started to realize that they need to figure out how to see these patients because there's so many of them coming, and partially people are living longer, particularly with Down syndrome and other diseases. And you know, so this is all, you know, a significant issue for them. But in terms of transitioning, you know, N of 1 patients who are receiving treatment, this is going to be something we're really going to have training programs. And we even talked about having a training program for adult neurologists that want to specialize in taking care of sort of pediatric people with patients with pediatric disease that are graduating to adulthood. So I think we are going to wind up keeping the patients ourselves until, you know, we wind up getting this kind of training in place where we have providers that we know are confident that they can do the care. One more thing that has been a benefit to getting older is that we, as patients have gotten older, some of our patients who are on regular infusions, you know, whatever number of months or weeks, depending on what the disease is, we are transitioning them away from anesthesia, which is great, because as they're older, they're a little calmer and they're easier to get to lay still. And so then the medical cost goes way down once you're just, you know, doing their infusions in clinic. And so I think that's been a big benefit. And but after they get past a certain age, somewhere in the 20s, it seems to vary a little bit, then they do have to go to the adult hospital if they have to come in, and that is very difficult because the families are not used to the kind of care that's provided on the adult side. They're very pediatric oriented, so we have work to do there too.
I want to also add, and I think it's really important that there's also adult patients who have not been diagnosed and not sequenced, and so it's not just children that are growing up with diagnoses and outgrowing things. It's really also important to reiterate that now that there's potential therapeutics along these lines, that really we should also be encouraging more sequencing in the adult community themselves and taking this forward. And I'm married to an adult neurologist, so I'm not hating on that. This is a discussion at home all the time, and I think, you know, so I think there are collaborators, and we can inform and equip them too.
We can have him on the panel next year with you, you know, so just making sure.
He's stroke, so only 90s and above.
We'll treat 90s and above. You know, we're not discriminating at all. And anything that I missed to ask, anything that you wanted to add on the topic of, you know, long-term evaluation?
Can I share an interesting data point that I think would be helpful to the community. Taysha Gene Therapies actually has a really interesting pivotal trial design currently, where as a primary endpoint, they are saying if any of 28 fine motor, gross motor communication milestones are gained, then that is sufficient, and they're using their patient as their own case study. This is based on data from the Rett Syndrome Foundation that shows that at age 6 and above, the patients are no longer gaining skills, they're maintaining or losing skills. I'm curious to get your thoughts on that, because to me, I think that solves one of the complex issues you guys are describing, which is how do you predict which of these gains you might have. I think it's a really interesting idea. And I also wanted to say to the last point of discussion, in their phase 1/2, they had 10 patients, and actually 3 of them were over the age of 20, and all of the patients were over the age of 6 because of the initial milestone as well. So I thought that was an interesting approach. Curious to get your thoughts.
Yeah,
Okay.
thank
Yeah,
you.
well, you're giving everyone a preview of my slides tomorrow. Yes, that is a very novel design, and it's very nice, and it takes advantage of the fact that those patients, because of thousands of patients in natural history that was run through an RDCRC grant for 15 years, we have very good data that shows they don't gain skills after age 6. Our problem in many of the other disorders is that we don't have that data to say they're not gaining skills, and many times they are gaining skills, but they're gaining them at some rate, and we don't know exactly what that rate is. So I think this is an excellent suggestion if we know the disease well enough. So anyway, yeah, we're part of that trial, and it's very interesting they were able to come up with that.
My comment is going to be that I appreciate that, and thank you for telling us about that. And I thank all the families who are in these protocols, because we ask all these disorders, Angelman, Fragile X, and all of these NF1s, we make these protocols with n-Lorem that are so big, and they're 2, 3, 4 days worth of testing, because we do want to cast that wide net, because the last thing we would want is to see clinical benefit but not be able to measure it and say, yes, look, we saw the benefit. And so while we don't aim to have many days of tiring evaluations, we appreciate it because it does really allow us to refine what we're doing and hopefully see change that's meaningful.
Yeah. Well, we are out of time, but I do want to thank my panel. This has been really interesting and fantastic discussion. Thank you very much.
Thank you.